عشان الوقت هكلمهم هسألهم ازاي يعملوها. شكرا.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. شكرا جزيلا دكتور محمد خشبة أستاذي الفاضل اللي كان السبب إن أنا خدت أطفال أصلا في الأساس، ما خدتش عيون. شكرا جزيلا دكتور محمد. شكر الجزيل لدكتور محمد زنون ودكتور وائل على الاستضافة الكريمة لتاني مرة في الورك شوب اوف اونكولوجي من 2019. دكتورة مروة كانت لسه بتفكرني. والشكر الجزيل لدكتورة إيمان ودكتور حنفي على الوجبة الدسمة اللي احنا خدناها. واحنا ما عادش قدامنا غير 4 دقايق أنا وإسلام هنتكلم في دقيقتين ودقيقتين. I will try to be as short and concise as possible. As Professor Imam, Professor Hanafi have stated that oncology is double-bladed. Either it could be underdiagnosed or overdiagnosed. This is our message from oncology. Sometimes we do unnecessary investigations, sometimes we are late in investigation. My agenda will include an introduction, how common is headache, headache types, headache classifications, how to approach by history and examination, what are the red flags, what are the neurological symptoms, and the secondary headache, what are the causes, and headache location I will finalize with neuroimaging and my home message. First of all, I have to denote that headache is the most common neurologic issue in pediatric population, affecting about 88% of children and adolescents. And of course, it's of great concern to children and the family, and of course for visits in the pediatric clinics and the emergency department. But we have to know that headache is usually a primary one, and a small population category who are life-threatening, and we should identify the warning signs. But how common is headache? From 5 to 17 years old, it's 20% reporting to be headache and to have headache. And tension is affecting about 15% of the children, and migraine about 5%. But many parents are usually worried that the child, their headache could be a brain tumor or a serious problem. But you have to know that it's only less than 3% of headache that will show brain tumors. And the most common is the stress and lifestyle issues. What about types? The International Headache Society just lists about 150 headache types, but we can summarize them in 4 groups: migraine, tension, mixed syndrome, traction, and inflammatory. And if you go to migraine, it's usually episodic with few minutes a month, and usually severe, sensitivity to light and noise, usually followed by nausea and vomiting, and it is hereditary in 60% of patients. It's a very important issue to ask about family history in headache. Number 2, we have the tension headache, which is occurring mainly daily, and the patients do not experience the same symptoms of migraine. But what about mixed? It could carry both migraine and tension. And sometimes we call it chronic migraine or transformed migraine. And the patients have headache more than 15 days per month. And the last one is the traction and inflammatory headaches, which usually signify the presence of illnesses or brain disorders, and usually it could be a brain tumor or bleeding. What about the classification? According to the onset, we have the acute headache, which usually is sudden, for the first time with symptoms which can resolve within a very short period of time. It could be either migraine or tension, and it can signify the presence of simple illness, and in athletes, exertion may cause headache, and sometimes it could be serious, especially if we have neurological symptoms. The second one is acute but recurrent migraine. It's moderate to severe, from 1 to 4 hours, and more than 4 times per month. It's usually throbbing and affecting the front and both sides of the head. And sometimes associated with pallor, nausea, vomiting, and irritability, and as I said, sensitivity to light, noise, and smells. What about tension headache? It's daily or frequent headache. It's usually caused by stress, tension, and anxiety, depression. And by the way, it is the most common type of headache. And sometimes it occurs more than 15 days per month. And if so, I should refer to a headache specialist. The last one is a chronic progressive headache. Unfortunately, it's usually getting worse and happens more often over time. And by fortunately, we can say it's the least common type. And when it occurs with other neurologic symptoms, I should go for thinking of a tumor. What about approach? Of course, history and examination are the key points in diagnosing any symptom. But in headache, we have to search carefully for growth, pubertal status, vital signs. Of course, all of us know what's hypertension, what it can do with a headache. And by the way, as regard tumors, patient can suffer from weight loss, can suffer from precocious puberty. If we have precocious puberty and failure to gain weight or even weight loss, we have to think of course, intracranial tumor. But what about skin? Skin is important as regard looking for systemic diseases or sometimes some neurocutaneous syndromes like neurofibromatosis and tuberous sclerosis. Of course, neurological examination is a must. We have to highlight the mental status, fundus examination, cranial nerves, motor sensory, coordination, deep tendon reflexes, and of course, gait. And you should look for asymmetry. This is one of the key points in neurological examination. And of course, any cerebellar signs and all the cerebellar tests we have to do, and we have to look for ataxic gait, as Professor Hanafi highlighted before. And what about the cranial nerves? Cranial nerves number 2, 3, 4, and 6 are of great importance because their affection can highlight a first indication for elevated intracranial pressure. What about our red flags? History and examination could be enough, but sometimes, although having primary headache being the most common, but of course, in order to differentiate between secondary and primary, you have to go for our red flags and our warning signs. Number one are neurological symptoms. Of course, altered status of mentality, weakness, diplopia, papilledema, any neurological deficit, especially focal, and if the patient is already immune compromised, signs of meningeal irritation, headache, which is triggered mainly by exertion and valsalva, what we call thunder clap headache, which is severe headache that peaks within few seconds, any systemic symptoms like fever, weight loss, rigidity, and progressive worsening of headache, and the red eye, and the neck injury, and the history of traveling. Of course, the increase in number per week, if there is keep getting worse, do not respond to simple therapy, wakening the child while he's asleep, and of course, absence of family history or the presence of family history of neurological disease. And we can mnemonic it in this SNOOP4, which is for systemic and for neurological abnormal signs and for an acute onset. And I'm highlighted the occipital because I will go for it later, and precipitated by valsalva, positional progressive, or parents lack, which means absence of family history. And we add a Y, which is a year, which is less than 6 years. It is an ominous sign. What about neurological symptoms? I mentioned seizure, steroid level, ataxia, lethargy, weakness, excess vomiting, of course, visual problems, as I mentioned, any personality changes I will skip, and slurred speech sometimes. What can cause a secondary headache? I mentioned that the primary headache is the most common one, but secondaries could be, of course, a tumor. As an oncologist, I have to confess, but I told you that it's may be less than 3%. Could be a brain abscess, could be a bleeding, it could be an infection, it could be hydrocephalus, it could be even a tumor, pseudotumor cerebri, some seizure disorder, trauma, or metabolic disorders. What about location? I will be finished within 2 minutes. The headache location. Number one, for migraine, it's often bilateral, frontal, or temporal, and minimum of 2 hours instead of 4, and the tension is usually diffuse and lasting from 30 minutes to 7 days. But if unilateral, you have to think of secondary pathology. I told you that occipital is something which have got a dilemma. All times ago, we think that occipital headache is something of concern, but later studies have said that occipital headache is something you don't have to bother about, and you have to deal with them like any other location. The last thing I'm going to speak about is the neuroimaging in headache. And as Professor Hanafi said, that in Guillain-Barré, I have to put in the guidelines, doing an MRI on the spine in order not to miss a spinal cord compression. I have to confess that the opposite is here in headache. Of course, we all know that imaging studies are causing some harm, exposing for radiation, sometimes costly, but they can highlight the high-risk pathology, and they can alleviate an anxiety for the parents, of course. And sometimes it's difficult to differentiate primary from secondary except by doing a neuroimaging. But doing a CT is exposing for X-rays. I have to confess also that CTs are usually used as an initial way, especially for acute headaches in emergency department, because of their reliability, accessibility, and quick results. And of course, they are very good in hemorrhage and in bone disorders. Usually, when we do a CT in emergency, we do it without a contrast. But if I'm thinking of a tumor, I have to use iodinated contrast, of course. But let me highlight this statement. In children less than 15 years, the cumulative ionizing radiation doses from 2 to 3 head CT scans could triple the risk of brain tumors. And the 5 to 10 scans could triple the risk of leukemia. Therefore, using an MRI sometimes, which is not using ionizing radiation, it's very valuable in diagnosing neoplasia and metastasis, either with a contrast, gadolinium or not, and especially for posterior fossa, which could never be highlighted by a CT. I can say that the sensitivity and specificity of MRI in diagnosing brain tumors reach up to 92 and 99% respectively. But for CTs, it's only 81 to 92. But while doing an MRI, sometimes we have some incidental findings, like non-specific white matter abnormalities, enlarged perivascular spaces, arachnoid cysts, and sometimes even Chiari type 1 malformations, and even some extracranial parts like sinusitis and mucosal thickening. But these are not typically relevant and would change the overall headache management. Therefore, we have to skip them while approaching headache. Therefore, a head CT is typically only recommended in the emergency setting in absence of an MRI. And of course, brain MRI is the neuroimaging modality of choice in assessing headache, particularly chronic headache disorders. My whole message is, although most pediatric headaches are due to primary disorders, a stepwise approach is essential to avoid missing secondary headaches. Evaluation and diagnosis of pediatric headache starts with a thorough headache and medical history, and of course, family history, and highlighting the risk factors either in history and in examination. And number 4, don't forget that our clinical sense, our clinical judgment, our clinical acumen remains essential in the decision of imaging and further management. And my last home message, which is the most effective message today, is excess exposure to CT scans in childhood increases the risk for development of cancer. As I said, oncology is double-bladed, either overdiagnosed or underdiagnosed, and my references, and thank you.
شكرا جزيلا استاذ دكتور احمد درويش على المحاضره الرائعه. And this very important practical clinical tips. And for sake of time I will introduce الاستاذ الدكتوره اسلام الهواري، وحده امراض دم واورام الاطفال وزرع النخاع جامعه طنطا، عشان تكلمنا عن موضوع مهم برضه يتشابه مع البيدياتريك اونكولوجي. والصراحه ان كل موضوع اتقال النهارده محتاج ورك شوب. انا يعني بقترح على الاستاذ الدكتور تامر حسان بعد كده ان شاء الله ان كان في العمر بقيه، يعني ان كل موضوع